I can do it if you want.
Okay.
Good morning, everyone. Thank you for joining PHCA for today's webinar entitled Understanding the Comprehensive Joint Replacement Mandatory Bundled Payment Initiative. My name is Rachel Delavan. I'm the Director of Research at PHCA. Before we get started, I have a few housekeeping items to cover quickly. If you've dialed in by phone, just please make sure you've selected telephone on your screen and enter your audio PIN. That gives me some control to eliminate any echo or problems we have. The webinar will be recorded and made available on the PHCA website. The webinar has been approved by NAB for 2 credits for nursing home administrators. I will email certificates to attendees in a follow-up email. That email will also have a link to the handouts and a link to the recording of the webinar. Attendees will be in listen-only mode, so when you have a question, please submit it in writing using the question pane. I'll use the time at the end of the formal presentation to pose those questions to our presenters. The objectives for the webinar today are to educate post-acute care providers on the features of the new CJR payment model, discuss how the payment model will affect those providers, and review your options in areas where CJR is mandated, including issues associated with developing a collaborator agreement with CJR discharge hospitals. So we're really glad today that we have David Marshall and Kimber Latsha from Latsha, Davis and McKenna here to join us. Thank you both, and I'm going to turn it over now to Kimber to start the webinar.
Thanks, Rachel. We appreciate it. I thank you, everyone who's joined us this morning for the presentation. I hope that you'll have a real appreciation for developments, and this being one of the first, that are reflective of coming value-based purchasing initiatives that will go from being voluntary, and this is the key word on the slide right now that you have in front of you, to mandatory. So to put that in context, let's just put this whole CJR program in context. And in order to do that, I think it's worthwhile to go back in time a little and look at some history and some developments so that we can have a context for what's happening, and it will help you address what's going to happen in the future as well. Okay, so in terms of context, we had the Patient Protection Affordable Care Act. We often refer to it as the ACA, but in reality, those first 2 words, patient protection, and it's interesting we had to pass a law to ensure patient protection, are in many ways the real emphasis of the law. Not, when we get past the enfranchising people to have insurance, much of this law that we're now feeling in a very real way is all about patient protection and a quality movement. Now, I say that with absolute certainty, and there's no question you're really confronting a strong, overwhelming quality movement in the post-acute world, in the acute world. It's all across the healthcare spectrum, and it's not ending, and it won't go away. And this is part of the implementation of quality initiatives, forced coordination, forced integration between the post-acute and acute care world, even if they're not ready for it. It's now mandatory, and the idea of participating in a bundled payment for care improvement program in a voluntary sense is moving away and heading in the direction of mandatory. Now, that's very significant. So in addition to the passage of the ACA, that was March 2010. Again, just putting some context for what we're doing today. That act created the National Quality Strategy for Improvement in Healthcare. That strategy became a written document in March of 2011. And it's really pushed so many things. Many of you, I think, are dealing, hopefully, with the reality of the IMPACT Act, which is, of course, the Improving Medicare Post-Acute Care Transformation Act. That word is, and that was passed in 2014, and in October 2014, and in some respects it's just a continued outgrowth of the ACA, the PPACA, which is transforming in a real literal sense the whole post-acute continuum. The idea that the ACA had implicit in it when it created voluntary programs for accountable care organizations, things that you've heard that were voluntary. The bundled payment care improvement initiatives, again, voluntary, all designed to do what? To integrate and coordinate post-acute and acute care so that we would become more efficient in the delivery of care and ultimately enhance quality. Break down the silos. Move away totally from the concept of fee for service to cha-ching, money in the bank every time someone goes in a hospital, goes into a nursing facility, goes into an LTAC, an IRF, back and forth, money paid, but what was the net result? Government's trying to get their hands around that and give incentives, financial incentives in the form of both penalties and rewards for discontinuing those practices and working together in an integrated sense to reduce cost and ultimately, again, to improve quality. And again, I say this with absolute certainty. If you look at what was done, this always comes first to the acute care side. So again, putting in context, what have we had since the ACA? We've had the Medicare hospital readmissions reduction program and the associated penalties. I mean, this is similar in some respects. I mean, it took the hospitals the first year of penalties to get into the game and realize this is costing them money. Then they started to move in the direction of preferred providers and recognizing that they needed to do something to control readmissions because it was going to cost them money. I'm suggesting to you that because we have a grace period, which we will talk about in the implementation of this program, which is the first year, that many hospitals, even the mandated hospitals, still haven't paid real attention to the implications of a mandatory bundled payment where they're the ones that are at risk, and we'll talk more about that as we go through the program. But the hospitals already have the readmission penalty. The hospitals already have the hospital-acquired condition reduction program in place that costs them money for infections and other conditions that are caused ancillary to their admission to the hospital. It costs them money. They already have a value-based purchasing program that rewards value. All of that now exists in the acute care world and came there first is transitioning to the post-acute world. Again, this is context for this program because this isn't the last of these types of programs that we will see. Okay, so what's happening in the post-acute world? When I talked about the Impact Act and transformation, think about what's happening. Think about what you have to report on July 1. The PBJ, and it's not, again, not peanut butter and jelly, but the payroll-based journal electronically and the data that will confirm staffing. Because what? In CMS's eyes, staffing is a reflection of quality. If you go to our 5-star program, which includes hospitals today, home health agencies, everybody's getting rolled into evaluation based upon a 5-star index. Well, in the post-acute world, for nursing facilities, staffing is a criteria. As we move to the Transformation Act and we look at reporting numerous quality domains and measures in a uniform sense across the whole post-acute world, whether you're an LTAC, whether you're an IRF, whether you're a home health agency, whether you're a SNF, there are certain domains, and they're the key care areas, whether it's skin breakdown, whether it's falls, the major areas of risk, generally speaking, in the post-acute world, all of those will have a common reporting requirement within your assessment instrument. You'll still have separate assessment instruments, but the domains and the reports that will have commonality and uniformity will be in all of those instruments. You'll become site neutral. That's where we're heading, and we're talking about that in the context of this bundled payment program today in a meaningful way. The silos aren't important. Really what's important is who in the post-acute world can provide the rehab care for the most efficient cost and at the quality level that is necessary. And by that I mean necessary, or you won't even get to participate, and you won't be able to be rewarded if you do well, even on the cost, if you don't show the quality. And that, again, is a condition of being a winner. Quality is a condition of being a winner under this program, and you'll learn more about that. But I'm giving you all of this context because I think if you have this big picture, it's easier for you to understand the implementation of this particular program. Again, it all revolves around the idea of value-based purchasing, integration, coordination, words that you've heard, and by that I mean integration, coordination between the acute care world and the post-acute world. Things that we've heard many, many times. I mean, you're all past the concept of preferred provider that grew out of the hospital penalty initiatives. Those agreements are out there and they exist. Who wins? Who gets picked? How do you get picked? It's all based on quality in many respects today and efficiency. So with that as a backdrop, that's meant to be the introduction to the program. Now, what's interesting, we're having this session on April 7th, and this program was actually implemented on April 1. And again, it's not all across the country. I'm going to give you some context for the magnitude of the program, but it involves roughly about 800 hospitals. And again, the hospitals bear the brunt of this. It's hospital-centric, the design of this model. And if you look at the CMS literature about this program, they talk about it in terms of a model. They talk about it in terms of a test. And why did they pick this particular model, and why did they pick hip and knee replacements? We'll talk about that in a second. So if we could flip the slide. Okay, here's our goal today, to educate you on the features of the new CJR. Again, we've given you context for the program in a preliminary overview. How does the payment model work, and how does it affect you as a PAC provider? What's your relationship with the hospital to participate in this? Is an agreement necessary? If so, what does that agreement look like? How do you get in the game? How do you get to participate? We'll talk about some of those things. What are your options in responding to CJR where it's been mandated? So we'll review those, and hopefully at the end of the session you'll have answers to a number of those questions. Okay. Now, as we move on to get into the specifics, this heading is called the background and what we're trying to eliminate, and we talked much about this in a second, but I want to give a little more context in terms of background. Why did CMS pick CJR, if you will, lower extremity joint replacement, LEJR? It's interesting, every time we have a new program, we have new acronyms to learn. I thought I was done learning acronyms, but it just goes on. And here a common acronym for this program is LEJR. You don't see it on this slide, but it's lower extremity joint replacement. And this test, or this program, involves 2 DRGs, and 2 DRGs only, 469 and 470. They're total hip and total knee. Again, you'll see this on slides. You don't have to take notes. Hopefully this will be a huge resource for you, for those that are in the mandatory areas and want to use it, and for those that are thinking prospectively about what will mandatory bundled payments look like. Hopefully it'll be helpful to you. But anyway, so why did CMS pick those 2 DRGs? Because total hips and total knees is probably the most common, at least according to CMS literature, surgical procedure that a Medicare beneficiary receives. And the costs of that procedure, which is interesting, is so variable amongst hospitals, even in the same region. And the outcomes associated with that are quite variable. So the idea is to put this model together, test it. Can we get get the hospitals, by integration with the post-acute community and physicians, to basically come up with the right cost that's fairly constant and one that embraces quality? So that's part of the testing in the model. So how much money is at stake when we're talking about this test? Well, in 2014, fee-for-service claims. Now, again, this whole program excludes Medicare Advantage recipients, anything that's capitated, anybody that's already in one of those programs. So Medicare beneficiaries that are in a Medicare Advantage plan will not be captured by this mandatory program. But again, the focus is on the hospital, and we'll talk about that in a second. But anyway, the size of the program. In 2014, fee-for-service claims data show that there were 478,000 Medicare discharges under those two DRGs that we talked about, 469 and 470, for total hip or total knee replacements. Okay, so in the participating hospitals that we're dealing with, CMS, where it's mandated, CMS is estimating that there'll be about 86,000 discharges that will be in the test or the model. So that's about a quarter of all, about 25% of all the discharges that will occur in the country this year, or actually when we have a whole full year, that will be captured by the model. Now, when we talk about what are the costs and allocating them, I think it's important for you to have this concept in mind. The CMS data suggests that when you go into the hospital for a total hip or total knee replacement, and you do it in the form of costing the episode for 90 days, so that includes the hospital, which is what is captured here, the hospitalization and the surgery, and then the post-acute care based on a clock that begins to run on the day admission to the hospital for 90 days. Includes all the physician services, all the ancillary services, OT, PT, all of that associated with the cost of the episode. And that's all bundled together. When you look at those costs and you allocate them, the CMS data suggests that 55%, this is on an average or a median, 55% of the costs are associated with the hospital stay. 25% of the costs are associated with a PAC provider, a post-acute care provider, or providers. And then another 20% is allocated to physician services or outpatient hospital services, other services generically. So that's how CMS allocates the bundle. Now, I've looked at some consulting studies done by consultants for hospitals that suggest as much as 35 to 39% of the cost is really a post-acute cost. So that's a potential huge piece of the pie that's in the post-acute continuum where hospitals need to look to be a winner under this program. So, and if you want to look at dollars and spending, roughly the model is going to apply to about $1.3 billion in episode costs in its first year in 2016. And will include, and that keeps increasing each year. By 2020, it's a 5-year program. It starts in 2016. It was originally targeted to start on January 1 of this year, and it, of course, didn't go into effect until April. There was a lot of pushback to even extend that date, but it went into effect on April 1. But there is a grace period. We'll talk a little bit about that. But at any rate, by 2020, CMS anticipates that those hospitals in the model will be accounting for about $3 billion in episode spending. And over the 5-year program, CMS anticipates saving $343 million out of those episodes. Now, they expect to do that in the following manner. They expect paybacks, and they're called repayment amounts. We'll get to some of this in specificity shortly, of $513 million from hospitals. Think about that. $513 million is going to get paid back to CMS over the course of this model or test. And CMS expects to pay out about $170 million to the winners. And if you're a post-acute provider, you could be included in the definition of a winner if you have an appropriate agreement with a hospital. The net savings to the program is anticipated to be $343 million. So again, that's the big picture of the program. And that's hopefully gives you an idea of how much money is at stake and what the incentives are to cooperate or to become, as you'll learn through this section, a collaborator in the implementation of the program. One final thing on the intro, and this is interesting. These regs were published in November of 2015, November 24th of 2015, to go final. That was supposed to have an implementation date of January 1, but if you backdate that to when the proposed rule came out, July 9, On July 9, the proposed rule came out. This was going to be implemented on January 1. It all happened in less than a year, even when you use the April 1 start date. This is reflective. We're getting close to the end of this administration. Their goals for quality, integration, and coordination, they're becoming rapid mandates. This was done very quickly, and the impact of it is yet to be determined. But the objective, again, is to force coordination and integration and to ultimately save money and enhance quality. So we'll see in this test whether it really does all of that. Okay, what are some of the new words? Now we're going to get into the specifics of the program. Okay, when we're talking about being a winner or a loser here, these are important words. There is first the alignment payment. That's a word that you don't want to see too often if you're sharing in an agreement, in a collaboration agreement with a hospital. Because as I talked about the $513 million that's expected to be paid back to CMS, an alignment payment really reflects the fact that you didn't meet the target price, and I'll get to explaining that in a minute. Maybe I should do that just big picture. It's on another slide, but in a big picture sense, when you're talking about an episode, you're talking about a DRG, and whether it's 469, whether it's 470, total hip or total knee, when we define this episode, again, this is on a slide and we'll get to it, it begins on the day of admission and it ends 90 days later. It includes everything in that episode. It's all, there are a few outliers that CMS will deduct from the cost, but CMS will calculate the actual costs related to that episode. Now, a hospital, the hospitals that are mandated, they already got their information that tells them what the target price is. That's based both on the hospital costs and regional costs. But CMS has developed, this is very similar to an ACO in the sense of whether you win or lose. CMS has developed a target price for this episode of care. And if you meet the target and you provide the care for, you provide the episode of care for less than the target, you can be a winner. Again, there's certain constraints, percentages that CMS adds on to it. We'll get to those specifics in a minute. If you exceed the cost, the target price, you're a loser. And that eventually takes you into the alignment payment issue. So if you're a loser, again, this is a mandate. This isn't voluntary, and this affects hospitals. They're the ones that really incur the risk. They have to pay CMS back the money that it cost to provide that episode of care that exceeded the target price. Now, that's an alignment payment. In comparison, if you drop down on the slide to the reconciliation payment, that's where you want to be if you're a hospital. That's a payment from CMS to you, assuming you met the quality criteria, for providing the episode of care at a cost less than the target price. So if you're a collaborator, and we'll explain this in a minute, if you're a post-acute care provider who has a collaboration agreement with a hospital that gets a reconciliation payment, and your collaboration agreement entitles you to share in a reconciliation payment, then you can be a winner and share along with the hospital in providing the care, the episode of care, at a price that's less than the target. So those are the two words by contrast. The repayment amount is what the hospital has to pay back. The alignment payment comes from a collaborator. So if you're a post-acute provider that has the inverse of what I just shared with you on a reconciliation payment, you're aligned with a hospital that was a loser in terms of the target price, then your contract would obligate you to pay and share in the hospital risk. You'd pay to the hospital, and the hospital would ultimately make a repayment amount to CMS. That's the repayment amount definition. Gain sharing. That's the payment from a hospital to you, again, if you're a winner. Internal cost savings. Hospitals can also calculate internal cost savings that derive from the efficiencies that CMS hopes this program produces. They can share those. Again, the government regulates this. Dave will talk about this later when we talk about some of the waivers in the program. I mean, there's some concern that the hospitals don't want to pay too much to an orthopedic practice for referrals. So there's some controls built into the system. We can't just hypothetically come up with internal cost savings. They have to be legitimate and based on sound accounting principles to justify now. Okay, the other two acronyms here, CJR, that's obvious, what we've been talking about, that's the acronym for the whole program, and then the two DRGs that are at stake in the program, total knee and total hip. Okay, for those of you that are listening and are really tuned in because you know this affects your area, this is an illustration of how it plays out in Pennsylvania. Again, there's 800 hospitals involved in the program roughly across the country. In Pittsburgh and here in Pennsylvania, we have 27 hospitals in Allegheny and Armstrong counties. Again, they're mandated to participate in the program. In Cumberland and Dauphin counties, we have, you can see all four of them right there. The other area of the state where there's a mandate is in Berks County. So there's 2 hospitals at stake. So that's the total number of hospitals. If you're not in one of these areas, if you're not a post-acute provider getting discharges from hospitals in the mandated area, this program doesn't affect you. But if you are, whether you have some type of an agreement with a hospital or not, your costs will be calculated in terms of calculating the actual cost of the episode for that participating hospital. Again, that's mandated to participate. Okay, as we talked about earlier, the program's to run for a 5-year period. It's already started, and those are the 2 DRGs. And now we're drilling down and getting into some of the specifics of the program. Now, the key point on that slide is the second one, which talks about the hospitals being accountable for quality and cost for the LEJR program. I mean, again, as I said at the beginning, it's hospital-centric. You as a post-acute provider, nothing will change for you as a practical matter in the way you bill for services. If there's a discharge from a hospital in a mandated area that's under one of these, the discharge is based on one of these DRGs, they're admitted to your facility, their stay, you will bill as a typical fee-for-service stay to the Medicare program, just as you do right now under the prospective payment system. So nothing will change for you in terms of billing. There should be some changes, and we'll talk about that in a minute, depending on more than a minute, but we'll talk about it as part of this session. There should be some changes, hopefully, in your relationship with the hospital if you're getting discharges under this program. Okay, the next slide. Oh, and again, on that slide too, key thing, as I said before, and why I don't think we have much attention from hospitals yet, is that there's a grace period. This April 1 time frame to the end of this year is really a time period where the hospital could be a winner, but there's no downside risk. So they're really not at risk. What CMS is doing is allowing the program to phase in without exposing a hospital to a loss, if you will, through an episode of care. But starting January 1 of next year, the grace period's over, and it means real money to the hospitals. I think it would really be helpful if we all got a chance to talk to, for those of you that are in the mandated areas, get involved in this program between now and January 1 of next year, when it really does have a financial impact on hospitals. Okay, as we talked about earlier on this slide, the hospital is accountable, and they have to meet the target price. The target price is something that's calculated by CMS. It's based on that particular hospital's costs and regional costs. And a hospital's told what the target price is. They get that information from CMS. So all of the hospitals that are mandated to be in this program should already have that information. Now, this slide defines the episode for you, things that we've talked about in trying to set the stage for what this is really all about. But for those of you that are already participating in a bundled payment initiative, then you're familiar with the concept of an episode of care. I mean, it's defined by the admitting DRG. It extends for a particular period of time. Under the bundled payment for care improvement initiatives, there's varying times, 30, 60, 90 days. Under this program, it's fixed. It's 90 days. And there's discussion in the preamble to the program about stinting. Hospitals or PAC providers or others that try to and stinting is an interesting word in the context of the program, defer costs until after the 90th day, readmissions. You'll be an outlier and readily identified if you participate in those things, and they'll eventually cost you money depending upon what that looks like. So again, this program is based on the concept that a person with a total hip or a total knee will get all the care that they need within those 90 days and hopefully have a successful episode. And the target price in CMS's mind will be met eventually because of the incentives. And it'll be all that care will be provided with enhanced, or at least at the level of quality residents, beneficiaries rather, are receiving right now. Now again, there are some procedures that are really outside of a potential episode. I'd call them outliers, and that's based on the condition of some of the residents, not residents, but patients that would be admitted to the hospital, some of their comorbidities that would make them something than a typical hip or knee replacement. And in those settings, CMS has developed some excluded services that wouldn't really apply to costing out the target price to see if you've met it. Okay, on to the next slide. Okay, so what hospitals are participating? Again, if you're a PAC provider in any of the counties that we talked about, Allegheny, Armstrong, Dauphin, Cumberland, or Berks, you should know the answer to this question. This slide here is actually from the preamble to the regs. It kind of tells you what hospitals are included. Again, if you're a hospital, that's the left-hand side of the slide, that's already participating in a bundled payment for care improvement initiative, then many of your discharges, or none of them potentially, will actually be included in this test or this program. There won't be any CJR episodes. Now, this is something that you can find out. Now, for the most part, CMS tried to pick geographic areas where the hospitals were not already involved in bundled payment initiatives for the total hip or the total knee replacement. I mean, they did a study, and there should not be too many hospitals in the selected geographic areas that are essentially disqualified from participating because they already are in a bundled payment initiative. That's what this slide shows. So the hospitals that are not, all of their discharges will be included, which is the right side of the slide. But you should find that out. I mean, you don't need to talk to a hospital that's so to speak excluded. Those that are included, which should be the vast majority in the geographic areas selected by CMS, are potential partners of yours in meeting a target price. Okay, how do you calculate the target price? It's really a complicated formula, and I'm not going to try to teach us all that formula this morning, but CMS does it, and they give that. You can see they do it twice a year. October 1, that's the CMS fiscal year, and the government's fiscal year, and on 1/1. Now, what that means is throughout the 5 years of the program, there's constant rebasing. And it's interesting because if the program's working and people are getting toward their target price, which you can see won't be hospital specific, just look further down in the slide. Initially, it's a blend of hospital specific and regional specific costs, but as the program begins to get into its latter years, it's all regional costs. So you're going to be arrayed, a hospital is going to be arrayed against its peers and measured not by its costs, but by the regional costs. And that target theoretically will go down over time, because you'll see that this program to me is, as I look at it, inherently deflationary as you try to hit these target prices. Okay, so that's all. So this is not something that we control as that you control as providers at all. This is calculated by CMS. It's given to the hospital, and they have to meet the target price. Okay, now here's the big criticism about bundling or ACOs generally. I mean, do they automatically contemplate a, so to speak, penalty, if you will, or a reduction in your rate? So the episode price, or the target price of the episode rather, is fixed. But in addition, CMS wants a piece of savings right out of the block. So they apply to the target price automatically a 3% discount. Now that discount can be reduced to 1.5% depending upon the variable of, a certain variable, and that variable is actually quality, the quality measurement. So if you achieve certain quality measurements, you can reduce, so to speak, the rate cut or the discount to 1.5% to be a winner. So in other words, technically to be a winner, you got to be not only get the target price, but 3% taken off that target price. So it's more than just hitting the target. Now, if you meet certain quality levels, you only have to hit the target less 1.5%. Otherwise, you have to hit the target less 3%, taken right off the top by CMS. Okay, I pointed out here again, as we said earlier, that CMS needs to communicate that episode price. So you can find that out, theoretically, from the hospital that you would want to participate in. It would be nice to, if you're thinking about a contract, and Dave will be talking about the specifics of this later on, to see how your hospital, your discharge hospital, is arrayed amongst its peers as you think about entering into a collaboration agreement. But the last bullet here is really key for you. I mean, business as usual in terms of billing the Medicare program under fee-for-service. Even though, of course, your costs are included in the mandatory bundle if that hospital is participating. Okay, here's the reconciliation process. And this is what we talked about in terms of being a winner or a loser under the program. This is all retrospective. So in the big picture, the way the program works, we've already talked about it. If you reduce that to a specific hospital, let's say a hospital has 10 total hip, total knees. That's a real low number. I'm just using simple numbers to help us with the concepts here. If the hospital had 10 of those hip or knee replacements in the aggregate for a year, you would take the target price times that 10 DRGs, so 10 times the target price for the hip and the knee, whichever one it was, and you'd come up with an aggregate number. Then that's CMS's number that would be applied to your actual numbers that are put together through the reconciliation, the retrospective reconciliation process, where they take all the billings from the physicians, from the hospital, from the PAC providers, everyone, from the therapists, everyone involved in that resident's care, and they aggregate those numbers. If those numbers in the aggregate are higher than the target price, you're a loser. If they're less than the target price plus the 3% or the 1.5%, then you're a winner. Now, the last slide here focuses on the fact that, again, this is a hospital-centric program. The only one eligible to get a direct payment from CMS and the only provider responsible to pay back to CMS is the hospital. You're not required to do that. Okay, how does the model work in terms of potential downside risk or upside risk? Are there any caps on any of this? Is this a huge exposure potentially? Well, here's how the program is phased in. Again, in year one, a hospital could be a winner, but there's a cap on what they could win in year one. These are called stop-loss limits, kind of like in the insurance business. You know, how much do I really put at risk? How much skin is in the game? In year one, the hospital is actually given a grace period, as we talked about, and they have no downside risk. Now, there's the caps going forward. You can only win so much depending on how efficient you are. So if you're extremely efficient, you still will be capped at those percentages, 5, 10, 20, 20. And on the downside, the good news is you'd be capped as well if you end up being a significant loser in the program. So there's limitations on the wins and losses. Okay, we talked about this as a driver in the program. Not only are we talking about money and efficiency and forced integration and forced coordination between post-acute and acute care providers, we're talking about quality. So it's great if you hit the financial goals that we just talked about. If you beat the target price by the 3 or 1.5%, great, you could be a winner. But not unless you meet the quality standard. And here's how quality is defined under this test or this model. There's a total hip or total knee complication rate calculation, and there is a a survey form that really comes from the National Quality Form. There's a whole bunch of survey forms that are out there. But this is one of them that it's called a Hospital Consumer Assessment of Healthcare Providers and Systems Satisfaction Survey. That's what that huge acronym stands for. And I think if there's one word in that acronym that's is the word consumer. So when you state it stands for Consumer Assessment of Healthcare Providers and Systems, that concept of consumer is well embedded in the ACA when we talk about patient protection, when we talk about a consumer actually rating a provider and grading the provider. That has real meaning under the ACA. It has real meaning for ACOs, and it certainly has real meaning in terms of dollars and cents for every hospital that participates in this mandated program, because it's a big part of the scoring process. And again, that's done by the patient, the consumer of the healthcare service, to rate you. And so the final piece, oh, by the way, that complication rate, that's done through a form that's over 90 pages long, to give you a sense of that. Now, again, it would be the hospital's responsibility to get this information completed and submitted, and they will need to do it. Then there's the patient-reported outcome measure, which is something that's done as part of, it's post-discharge, and it's a report that it comes directly from the patient, could be done, so to speak, by someone working at the hospital with a follow-up phone call, could be done by a PAC provider, but again, we don't typically have the infrastructure, and that's why it's hospital-centric. CMS believes they have the infrastructure to coordinate and integrate the care and follow up and confirm consumer or patient satisfaction and getting this data that needs to be reported about the patient outcome, the PRO, patient-reported outcome data. Okay, so those are the quality measures. How does that quality formula really work? Well, the complication piece of this, again, which is a huge form, lots of pieces to it, is 50%. Now, how did the care work out? Were there complications? Were there readmissions? If not, you're going to score very high, potentially, on that piece of it. You could get all the way up to 10 points. It's 50% of the graded value of the whole formula. The whole composite score is 0 to 20 points. So for each episode, you're going to get measured. Then there's the survey. Again, you got to get the consumer to ultimately give you their results. And that's a huge percentage. 40% of it comes from what the consumer thinks or the patient thinks about the care that was provided to them. And then the follow-up piece is that, which we talked about, the patient-reported outcomes. What really was the outcome? Is the patient still complaining of any pain? Those types of things that are potential variables in your points. Again, small amount, only 10% of the total puzzle, but could be valuable to you in trying to get to that 1.5% discount. Because so once all of that data is in, the hospital gets ranked, and they're going to have to be ranked at a certain percentage in order to qualify for a payment. Here's how the quality lines up in terms of potential payments. Okay, so a reconciliation payment, that's if you're a winner. That's that new word, reconciliation payment. You could get paid by CMS if you meet these criteria. There's the minimum scoring. Acceptable, 4 points or more, good, excellent, you're at 13.2 on a scale of 20. How does all of that weigh into the discount or the, quote, rate reduction piece of this? If you're at excellent, you get it reduced to 1.5%. So see, there's obviously an incentive to be at the 13.2 level or higher, because if you're going to be a winner, you can start winning at 1.5 rather than trying to reach the 3% barrier, so to speak. Good gets reduced to 2, and if you're just acceptable, there's no reduction. Okay, anything below that, you don't qualify for a payment. Now, that's an overview of the program. That's how it will work. Now, what are the beneficiaries' rights and concerns related to the implementation of this model? This is always a big issue. Does the beneficiary, in a system like this, where there's obviously huge incentives for the acute care world to collaborate with preferred providers are actually contracted providers, does the beneficiary retain any choice in terms of the location of the discharge? Can they pick their SNF? Can they pick their home health agency? It's pretty clear in the program that the beneficiary does retain that right, just as they do for ACOs. Those are not closed networks yet. Beneficiary choice remains something that's important to CMS under this program, but you'll see that there's some caveats and growing flexibility. So when you go into the hospital and you have the surgery and you're getting discharged, what does the hospital need to communicate in order to protect the beneficiary? Well, if it's a participating hospital in the mandated program, the beneficiary needs to know that, and that information needs to be provided to the beneficiary. Their hospital's also supposed to communicate that the provider has choice. Not the provider, but the beneficiary has the right to choose and use the provider of their choice. Now, as part of, so to speak, ensuring that right, hospitals are required to provide a list to the beneficiaries of all the packs that meet certain quality standards that could be available for their care. But here's the real kicker, and that's the last bullet. Hospitals can actually recommend a preferred PAC provider or providers to beneficiaries under this program. Again, it's pretty clear that the program says that they have the right to choose, but the hospital discharge planner can actually recommend a preferred PAC provider to that beneficiary. And I'm sure you're thinking, well, that'll have a huge potential impact on the decision, and I think hospitals certainly think that it will. And CMS recognizes that that's important, because if there's collaboration, if there's integration, and there's the thought that through that coordination of care there'll be cost savings, and those particular providers do it well at the appropriate quality level, CMS is letting the hospital tell the beneficiary that that's our preferred provider. So as part of that, there are notices that's listed for you here. What do we have to tell? And in terms of a PAC provider, if you're getting a discharge, you need to let them know. This is the only thing that's in the reg that's mandated for the PAC provider, that you're really participating in a sharing arrangement. Now, if you're not in a sharing arrangement, and Dave will talk more about that, that's essentially a collaboration agreement where the hospital is able to shift some of its risk for the downside to you, but also transfer some of the gain on the upside to you as collective winners if you do it well under that collaboration agreement. If you are a party to a collaboration agreement, that has to be disclosed to the beneficiary when they come to the facility. Most of the notice requirements in terms of beneficiary protections are really imposed upon the hospital. So again, that's a quick overview of the program, but should give you a sense of what it is. And saying that, I'm going to turn it over to Dave to get into some of the waivers, some of the compliance requirements, and really to drill down into the nature of the collaboration agreement and what that would look like.
Okay, thanks, Kimber. Yeah, what we want to talk about now is putting this into practice. You know, we've gotten a sense, hopefully, that everybody's gotten a sense of what the program is, but now how is it going to actually operate if it operates according to what the regulatory scheme and the plans of CMS are. And before we get into some of that, I think it's important to talk about, like most initiatives that CMS has going on, and if you're going to go to the CMS innovation page, but what's a common theme amongst all of them is, again, they're putting quality to value-based purchasing to tying it to reimbursement. And the way that you do that is sometimes inconsistent with the existing regulatory and compliance schemes that we have here on the books. So like many of the other initiatives that CMS has put out there, with this CJR program, they're allowing some flexibility to meet the program goals. And what they really mean by that is that, at least as far as we're going to talk about immediately, there are waivers essentially here to get you outside the loop of some of the incentive prohibitions and compliance anti-kickback statute regulations that are out there right now. So if you look on the slide here, there are some exceptions to beneficiary incentive prohibitions that are out there. I think we probably all know at this point, we've all been beaten over the head, that you, generally speaking, the CMS and the OIG have a problem with healthcare providers providing types of incentives or any kind of remuneration to a beneficiary because they're concerned that that's an inducement, an impermissible inducement under the anti-kickback statute. Well, for this CJR program, the government's given us a little bit of flexibility here, or really I should say they've given hospitals a little bit of flexibility here, because it's important to note that these types of incentives are allowed and permissible for the hospitals and not the post-acute providers. But hospitals under this program can provide certain types of in-kind incentives to CJR beneficiaries. So what that really means is they can provide incentives that don't amount to cash. What they really are talking about are incentives that are either a preventative item or service that's tied to the medical care that's being provided, or tied to a specific goal that's consistent with the program's goals. So let's talk about the goals real quick. An incentive can be provided that helps the beneficiary adhere to a drug regimen or adhere to the care plan or help to reduce a readmission or a complication. And again, what we're talking about are in-kind incentives, and most of that relates to devices and technology. And the government has said that a hospital can provide technology items whose value doesn't exceed $1,000 in any one CJR episode. So, big picture, in order to keep a patient on the plan of care throughout the episode of care that we're talking about, in order to help ensure that we've controlled costs, we can give them a piece of DME or a piece of equipment that'll help them meet one of these three goals. Note that the OIG, which enforces fraud and abuse, and CMS can review this stuff at any time, so certainly if any hospital runs afoul of these parameters, they're going to be in trouble under the anti-kickback statute. But again, big picture, like most of these demonstration or incentives, CMS is trying to think of ways to cut some of the red tape and cut some of the rigid compliance issues if it's going to help further the goal of the programs. Similarly, CMS has issued a number, in this case 3, waivers to existing regulatory provisions as a means of helping the participants in the CJR model control costs and deliver higher quality services. Let's talk about 3 of those. The first one, and the one that directly relates to the post-acute providers and the SNFs here, is the 3-day hospital stay waiver. What it essentially does is CMS is going to allow hospitals to discharge CJR beneficiaries when they desire.
Dave, are you there? This is Rachel. If you can hear me, we've lost you. I apologize to the attendees. We'll try to get Dave back on the line here.
I'm connected. Nothing happened.
Dave, I can hear you now.
Rachel, are you there?
Yeah, can you hear me?
Yeah.
Yeah, we can hear you before.
We always could. Yeah, we always could hear you.
Okay, there was like a 30-second, 40-second period where it was silent. I couldn't hear you.
Oh,
I think we're up now.
Are we back up now?
Yep.
Okay, everybody. Sorry about that glitch. I would give you an explanation, but that's not my forte, so I'm not going to try to wing that one. Let me go back, and hopefully this isn't too repetitive, but let me go back to what we were talking about, which are the policy waivers that CMS has put into place to help the CJR program move along. And the one that we were talking about was the 3-day hospital stay waiver, which applies in years 2 through 5 of the CJR program. And essentially what it would do would be to allow a hospital to discharge a CJR beneficiary really at the hospital's desired time, and maybe in less than a 3-day hospital stay, without compromising the SNF's Part A reimbursement obligations, and without holding the SNF to that 3-day hospital stay as a condition of Medicare Part A payment. Now, the catch to this, and the trigger for the SNF, is that in order to take advantage of this waiver, the SNF has to have a 3-star rating for 7 of the last 12 months prior to the discharge. And as we know, CMS is going to post a list of qualified SNFs in advance of each calendar quarter, which specifically related to the CJR. So the real question for you as a SNF provider, this is a very small picture of the big picture of what it means under the rating system, but for you in particular, if you are collaborating with the hospital on a CJR program, if you drop below that 3-star rating, then you're not going to be able to accept or get paid, frankly, by the Medicare program for a discharge of a resident who had less than a 3-day hospital stay. What that means is, or what it really is going to be contemplating is, it's more important than ever for those of you that are participating in the CJR collaborator agreement to make sure that you at least meet that 3-star rating. So that's going to be something to keep an eye on as we move forward. The second waiver and third waivers really are more reflective of home health, but they're important as you go through the post-acute provider component of the CJR program. There's a telehealth waiver out there that essentially does 2 things. Number one, it's going to allow certification for home health services via telehealth rather than the face-to-face encounter that's normally required. And number 2, it's going to allow telehealth visits to originate in the patient's home in a waiver of what the existing rule is as well. So the whole point to this waiver is to encourage the use of telehealth services at the front end and on the site visit requirements for home health as a means, ideally, of controlling and cutting down the costs of the entire episode. And similarly, they've waived, if you look at the next waiver, a post-discharge home visit waiver. Historically, there's been a physician direct supervision requirement, which means that on those types of visits, there's actually got to be a physician present to be covered under the home health program. Under this waiver, it's going to allow nurses and non-physicians to conduct the home visits without a need of the doctor to be present there. So again, the purpose of the waiver is to control and lower costs so that the participants in a packed bundle episode can meet the target prices. So that's kind of some examples of what CMS has done to try at least to relax the regulatory scheme so that providers can achieve the goals and meet the target prices that are set. So how then does the CJS mandate really draw providers together, and what are the program requirements that cover these types of arrangements? And I want to talk about this kind of in a increasingly specific focus. I want to talk about the big picture of what's required and then getting down to some of the nuts and bolts of the regulations that really do govern this pretty intensely. Big picture, and we've talked about it throughout the presentation here. Under the regulatory scheme, hospitals may elect to execute sharing agreements with other providers. The key term here is may. Although the CJR mandate is applicable to all hospitals in the covered areas, there is no mandate for those covered hospitals to actually enter into sharing arrangements with their post-acute collaborators. I think what we'll talk about and what we have talked about are reasons that make that attractive to the hospital, but it's important to note that the hospital doesn't have to do that. They can go it alone if they choose to do so. But if they're going to enter into a sharing agreement, they've got to enter into it with approved collaborators, and you see the list there. And Kimber's talked about that. We're talking about the SNFs, the LTACs, the IRFs, physicians, group practices, home health agencies. That's the pool of providers that are the potential collaborators for the hospital. if they're going to do this. Now, let's talk about the general requirements for these types of arrangements if you're going to go into them. And it's important to note that if you have a chance to look through the regulatory scheme for this CJR program, it is very, very specific and very detailed on how these financial arrangements have to be structured and how the actual agreements between the hospital and the collaborators have to be structured. It's almost a point-by-point type of regulation that if you're going to enter into these relationships, you need to follow. But let's talk about the general requirements here. As a base model, certainly a hospital can't make any type of gain-sharing payment or receive any alignment payment with a post-acute collaborator unless they've established a written agreement consistent with the regulation. That agreement is subject to review by CMS at any time, and ultimately, and we'll talk about this a little bit more nuanced later, but ultimately it's the hospital that's responsible for compliance with any of the executed sharing arrangements to the extent that the hospital's governing body has to go oversee and review and approve them. This next bullet point down here is a very important one for you as post-acute providers because the regulatory scheme requires the hospital to develop policies on how it selects collaborators and establishing the quality of care standards that it's going to impose on the collaborators. Kimber's talked about this throughout the presentation here. This payment structure and the episode is a function of quality care and meeting care goals in addition to meeting economic pricing goals. And the scheme allows the hospital to not just have to meet its own quality metrics, as we've talked about, but it also enables the hospital to impose quality standards on its collaborators as well. So what the regulation does is it requires the hospital to develop policies on how it's going to select collaborators and establish those quality of care standards. This is absolutely key for you as a potential collaborator with a hospital, and we'll talk about the negotiation process, but this is kind of tip one. This is one of the first things you ought to be asking for from any hospital that you're talking to about entering into an agreement, because they have to have these by regulation, and you need to know what they're expecting to memorialize into one of these collaborator agreements. So very key point from the regulations putting this relationship into practice here. Now, beyond those initial general requirements, there are a number of requirements that apply to the actual sharing arrangement itself. And obviously, it's got to be reduced to the collaborator agreement that you're going to be executing between the hospital. There's also a regulatory provision that makes it clear that participating in a sharing arrangement is voluntary and must be without penalty for non-participation. And what that means is that a hospital can't, by regulation or anywhere else, force you into it because that would be a prohibition under the regulatory scheme. Hospital might very well want you to participate in a collaborative agreement, and you may want to as well, but there is a regulatory provision that prevents a forced participation. From a timing perspective, and we do have some time here, but the regulations state that before you enter into an arrangement where you are actually going to share risks and costs, where there's an alignment payment, where there's a gain sharing payment, you have to enter into an arrangement before the care is furnished to a CJR beneficiary who's going to be subject to one of those risk and sharing arrangements. So remember, the program's already underway. It started April 1. If you are looking to enter into one of these relationships, you've got to enter into it before you're going to accept the beneficiary for whom you're going to share risks and costs. You may already have some of these folks into your facility. You just wouldn't be able to get paid or be responsible for an alignment payment about them. Again, it's the next year that starts both the downside risk and the upside risk limitations. So, or the downside risk limitation starts in the next year. So perhaps over the course of the rest of this calendar year is the time to get these types of agreements into place. Now, we talked about it on the last bullet point earlier. To receive any gain sharing payment from the hospital to you, you've got to meet quality criteria established by the hospital for this episode of care, which is really going to be the basis and based on those policies that the hospitals put together. So let's talk about a little bit more of the gain sharing and alignment payment the regulatory scheme says you can and can't do with them. Here's a number of the limitations. First of all, both of those payments must be related to a CJR episode in the calendar year when either the savings or the loss was created. What that really means is that you can't pay it forward or pay it backwards. You can't do any kind of advance payments, hedging your bets that we're going to be a winner or paying in on the assumption that we may be a loser. That's not permissible under the arrangement. It's also, from an anti-kickback and compliance side of things, it takes away the argument that any payments from the post-acute provider to the hospital could be viewed as kind of payments for referrals or continuing stream of referrals. Which leads me, of course, to the second bullet, which is kind of a standard anti-kickback statute prohibition. Whatever those payments are and whatever methodology that the parties come to create and calculate those gain sharing or alignment payments can't be conditioned on the volume or value of CJR beneficiaries that cycle between the parties or any other referrals that are generated between the hospital and its collaborators. One of the terms that Kimber talked about from an acronym perspective was the internal cost savings issue, and we'll talk about that in a second with respect to the gain sharing, but it's important to understand how that's defined by the CJR regs. Internal cost savings identified for the hospital have to be calculated according to GAAP, and they have to reflect actual savings achieved by the hospital itself. Internal cost savings for purposes of calculating these payments aren't the savings that you as a post-acute provider might see as a result of what's going on here. They're only the savings that the hospital itself has achieved. And then a final big picture sharing requirement is any of the payments made, either gain sharing from the hospital to the post-acute provider or from the post-acute provider to the hospital in the form of an alignment payment, has to be made through an electronic fund transfer so that CMS can track everything. Now, let's talk specifically about the gain sharing payments and what they can and can't be. Again, the amount that the hospital will pay the post-acute provider has to be derived solely from the reconciliation payments that the hospital receives from CMS, the internal cost savings the hospital realizes itself, both or one or the other. It can only be a payment from the hospital to the post-acute provider from one of those two or both sources. The payments have to be actually and proportionally related to the cost of care of the CJR beneficiaries seen during that year. They can only be distributed on an annual basis and not more than once per calendar year. And here's the cap and the limit on that. The aggregate annual gain sharing payments that the hospital makes from its reconciliation payments, which again is what it gets as a winner from CMS, can't exceed the amount of the reconciliation payment. So in other words, the hospital can't pay out more than its reconciliation payment to its collaborators, because that would be seen as some kind of inducement or an anti-kickback statute problem. The methodology for how this gain sharing amount is going to be calculated has to be based in part on quality care measurements, much like the hospital is going to be held to quality care standards as well. And that's all got to be memorialized in the collaborator agreement. On the flip side, the alignment payments, these payments that are made from you as a post-acute provider to a, quote, loser hospital, first of all, they can't be paid prior to the calculation of the repayment amount. In other words, again, you can't advance this payment to the hospital, and the hospital can't use this alignment payment to subsidize other operations that aren't indexed to its CJR costs and operations. This alignment payment can't be a loan or an advance payment to the hospital, because then it's suggested that it would be indexed to referrals and other business. And here's the limitation from the alignment side of things. In the big picture, the hospital can only downstream 50% of its risks that it has with the government. In other words, remember, the hospital has a repayment amount if it's a loser under the reconciliation. If it's a loser under the reconciliation and has to make a repayment amount, the hospital can only downstream 50% of that repayment amount to its collaborators here, okay? So, and on top of that limit, in addition to only being able to downstream a total of 50%, the hospital cannot share more than 25% of its responsibility with a single collaborator. So, just doing a little simple math, if the hospital wants to share 50% of its repayment risk with its collaborators, and if it wants to share the full amount that it's allowed, it's got to have at least 2 collaborators who have agreed to share 25% of that risk each. So what that tells me from just a logic perspective is, my guess is that most hospitals, or a good chunk of them, are going to want to try to share as much of the risk as they can, and they will at least have to go to 2 or more collaborators, depending on what the collaborators' agreement is and how much risk they're willing to take on, so that the provider can get up, the hospital, can get up to the 50% level. So you may have a hospital that has risk-sharing agreements or collaborator agreements with multiple SNFs, with multiple home health agencies, and multiple physicians and physician groups in order to get up to that 50% level. Or they may simply want to choose and deal with their most, preferred type of post-acute provider. But that's the limit on what the alignment payments can be done. And again, all of this has to be memorialized in the collaborative agreement that you're getting to. Now, with those parameters, there's yet another regulation under the CJR that goes through and walks you through specifics of what actually also has to be in those provider collaborator agreements. The agreement has to specify the parties to the sharing arrangement, the date of it, and the purpose of the arrangement. It's got to put forth all the economic terms, including when the payments are to be made, what the methodology is, what the formula is for any gain sharing or alignment payments. It's got to have safeguards in there that tracks those regulatory requirements that we just talked about, so that it's done and memorialized by contract. And it's also got to address plans on care design, changes in care coordination, and how success will be measured. Again, the goal of this program is that by forcing collaboration between all of these parties, the parties are going to figure out ways to save costs and yet ensure the quality of care at the standards that CMS has desired. And the agreement itself is supposed to reduce to writing how some of those designs and changes are going to be implemented. So, for example, the agreement is supposed to include management and staffing information, and specifically addressing the type of personnel who are going to be providing the CJR services at the post-acute level. In other words, you're going to have to talk about how you as a SNF or a home health agency are going to actually provide care to CJR beneficiaries in this bundle, and how that care model is going to help improve care and control costs. The agreement has to include a provision that everybody's got to comply with the beneficiary notification requirements and all the record retention requirements as well. There's got to be a rep and a warranty that the collaborator, that would be the post-acute collaborator, is in compliance with Medicare enrollment requirements, including having an active NPI. So my aside to that is that make sure that your Medicare, Medicaid revalidations, or certainly your Medicare revalidation, is in and up to speed, so that you're not erroneously dropped off. The regulations obligate the collaborator to have a compliance program that includes oversight of its obligations under CJR. We know that those in the SNF industry have been under a mandate since the Affordable Care Act of having a compliance plan, but this is something that probably is going to have to be added to your existing plan, perhaps a specific work group within your compliance committee or something, to ensure that you're actively overseeing your obligations under the collaborative agreement and that you're complying with the regulatory scheme. We talked a little bit about this before, but the agreement should establish the methodology for how the hospital is going to calculate its own savings, its internal cost savings, based on the care redesign elements associated with this, with your collaborators. Again, we went back and we talked about this earlier, that the internal cost savings can't be those of the post-acute providers. It's got to be the cost that the hospital itself saves, and those methodologies have to be set forth in the agreement. We talked about the quality criteria that are going to be used to determine gain sharing amounts. And the last bullet's important because it's a CMS mandate. If for whatever reason CMS overpays the hospital based on a reconciliation, and then from that reconciliation payment, the hospital has paid the post-acute provider, if that initial reconciliation payment was an overpayment by CMS, then the hospital has to have the ability to recoup that gain-sharing payment from the post-acute provider in order to return it to CMS. So, as always, CMS will ensure that they get their cut and ensure that they keep any overpayments that are erroneously made. From a documentation standpoint, the hospital has to maintain a current and historical list of all its collaborators, and they have to report that list to CMS. The hospital and the collaborator also have to maintain all documentation of the payment, receipt, and any gain-sharing alignment payments that are attributable to CJR beneficiaries. So in other words, you as a post-acute provider are going to have to keep records of all the claims that you submit to the Medicare program for CJR beneficiaries. You're going to have to keep records of any of the alignment payments that you make to the hospital and records of any of the gain-sharing payments that you receive from the hospital. And you've got to keep all of this stuff for 10 years following the end of your participation in the CJR model. So CMS is going to have access to this data. Where I had left off, I think, with everybody was talking about some of the documentation requirements that are imposed on all of the parties in the CJR bundle. First of all, the hospitals have to maintain a current and historic list of all collaborators and report that list to CMS. So clearly CMS is always going to know who's part of any of these collaborations. Both the hospital and the collaborator have to maintain documentation of the payment and receipt of basically all payments, meaning you as a post-acute provider would have to be able to provide access to any of the claims submitted to Medicare for CJR beneficiaries, and you'd have to be able to document any gain-sharing alignment payments you received and or paid in to the hospital. And you have to retain all this documentation for a minimum of 10 years following the end of your participation in the CJR model. So it's an ongoing requirement for documentation. So what I was building up to was, how do you initiate these discussions with the hospitals, and what issues are likely to arise in the negotiations in trying to put this into practice? And I think in some respects, one of the things you've got to do before you even start talking to the hospitals is do some homework on yourself and your own operations before you even enter into the discussion, so you know where you are and where you stand. For example, as Kimber mentioned before, I mean, it's incumbent upon you, first of all, to figure out what are the local hospitals that, A, not only refer the hip and knee patients to you, but are those hospitals under and covered under the CJR bundle, or are they exempted from it? And then from your end, you need to know things like what are the volume of these patients at your facility, and how many folks are we really talking about here to you, and then what are the economic implications of this to you? What are your costs in caring for those particular patients once they come to your facility? What's the duration of stay for CJR beneficiaries in your building? How do you play into the overall cost that the hospital is going to have to try to meet through that target price? I think you need to know the answers to where you are before you can really get into a good discussion with a hospital. Because the reality is, as Kimber mentioned, is that if you accept as a PAC provider one of those hip and knee discharges from a hospital that's in a geographic area that's covered by the mandate, then whether you have a collaborative arrangement or not with the hospital, your costs are going to be included in the hospitals for purposes of its measuring, of getting measured by CMS. And I think in some respects that in and of itself is going to encourage the hospitals to reach out to its post-acute providers as a means and an effort to try to share some of the risk. So if you haven't had those discussions with the hospital, and perhaps that hasn't occurred yet because the hospitals aren't concerned about it yet because we're in a grace period, I suspect that that's going to happen sooner rather than later, because ultimately it is the hospitals in this model that are on the hook for things. So conceptually, I think you've got two different avenues to develop these agreements. We mentioned earlier in the session about preferred provider arrangements, which are becoming more and more commonplace and really are designed to integrate operations and improve quality, but also to address the hospital's readmission rate problem. In large part was driving a lot of that stuff, because the readmission rate is a penalty to the hospital, and they want to partner with folks that aren't going to penalize them. So a lot of these preferred provider arrangements started popping up as a means of addressing not only that, but also addressing some of the coming care issues. That doesn't necessarily mean that these types of arrangements are shared savings arrangements like an ACO. But there's certainly a means of ensuring a stream of referrals from the hospital to the SNF, and they're becoming more and more favored, I think, by the hospitals as a means of controlling the providers to whom they discharge. Now, if you have one of those types of agreements in place, I think a CJR amendment to that agreement is something from a conceptual process that you can use to tie in the CJR mandate to your existing relationship with the hospital. If you don't have a preferred provider arrangement, you could still just deal with a CJR type of relationship with the hospital if you want, or you could develop a comprehensive type of preferred provider arrangement. It's kind of up to you. But I think those are the two avenues for putting this into practice with the hospital. Now, from a negotiation standpoint, again, we talked about in advance what you should think about from your own perspective before you get into negotiations. But I think one of the things you need to think about is how much risk are you willing to undertake in the format of an alignment obligation in exchange for receiving any of the gain sharing payments. Remembering, of course, that the max you could agree to is a 25% figure. But what that's really causing you to think about is who is the hospital that you're partnering with. You know, it's really a function of determining whether this hospital has the likelihood or the capability of being a winner under this program scheme, or is it really just going to be a losing hospital that is doing nothing really more than trying to mitigate its repayments that it expects to have. And that's going to play into perhaps on how much of a risk of an alignment payment that you're willing to enter into. You should think about the types of quality measures that you as a provider can implement and can control, because again, those are going to have to get into the ultimate collaborative agreement. So you should be thinking in advance of what type of quality measures that you can control and be measured by, as opposed to letting the hospital kind of top-down mandate what type of compliance and quality measures you're going to look at. Like every agreement, you've got to set it for a term, and you've got to deal with ways of getting out of it from a termination perspective. Again, the CJR program is a 5-year program, and CMS is going to evaluate it annually and conduct those reconciliations as we talked about. So I think as a practical matter, ideally you'd want to structure this agreement over the term of the CJR program, recognizing that the first year is really not much of a downside, and then evaluating it on an annual basis. And what that really kind of means is that there ought to be some kind of escape clause. You know, ideally you can get a without cause termination provision in there to get you out of this relationship if it proves not to be beneficial or economically harmful to you, especially if you're going to be partnering up with one of those hospitals that's constantly in a repayment mode to CMS, and you're really nothing more than their go-to for getting some relief from the payments that are going back. Like every program that CMS puts into place, there's a sanction process to it that allows CMS to sanction the hospitals primarily, but in some cases the collaborators for failing to comply with the regulatory requirements. All the more reason to have that compliance committee monitor this as required by the regulations. But some of the non-compliant things that CMS is going to be looking for is avoiding high-cost patients, targeting the low ones, failing to provide beneficiaries with the required notices and allowing choice. The choice issue may be more on the hospital side of things, but the notice issue would apply to both the hospital and the collaborators. And of course, failing to follow any of the provisions of the collaborator agreement is subject to sanction for both parties. If you want to know what kind of penalties could be imposed, well, the hospital, it runs from a warning letter to requiring a corrective action plan by the hospital, reducing the reconciliation payment or maybe even eliminating it. If it's the collaborator's issue, requiring the hospital to terminate the collaborator agreement and prohibiting further engagement in this model by that collaborator, or ultimately terminating the hospital's participation in the model. So there's a number of issues that, or sanctions that CMS can impose, some of which actually would fall on us and the post-acute community. We talked about this risk area earlier, but again, if you're going to get into this game with the hospitals, you've got to make sure that you're at least meeting that 3-star facility requirement, because part of the incentive of the hospital, of course, is to get that CJR beneficiary out of the hospital as quickly as they can. And if they can get it out in less than a 3-day stay, they're going to do it. And that's great for the hospital, but if you are the admitting post-acute provider afterwards and you don't have that 3-star rating, then you as the SNF aren't going to be able to do a billing to Medicare for that Part A stay. So from a negotiation perspective, you need to address or try to address in the collaborator agreement that you wouldn't be obligated to accept those beneficiaries without a 3-day stay if you're not meeting the 3-star requirement. So to be frank, if you're in that position, I'm not sure that the hospital is going to partner with you anyways.
Well, and as a practical matter, Dave, let me just add, I mean, the hospital has to provide notice to any potential beneficiary, well, to any beneficiary on discharge. I mean, they have to have in the notice requirement any nursing facility on their list. Like we talked about earlier, they have to have a list of all PAC providers. And if any one of the SNFs has a 1 or 2-star rating, they have to actually identify that for the beneficiary, because when the beneficiary goes to the nursing facility, their stay won't be covered by Medicare. They'd be responsible to pay themselves. So, I mean, the hospital is absolutely required to disclose that. So if you're not a 3-star facility, the hospital is going to be careful to make sure that in their minds the beneficiary doesn't go to your facility.
Yeah. We talked about some of the other risk areas and things, but the collaborator agreement is something that really needs to be carefully drafted and reviewed against the regulatory scheme, because both parties can be sanctioned for putting together an arrangement that's not in compliance with it. And of course, as we just kind of talked about, you've got to make sure that the appropriate notifications to the beneficiaries are put together in advance and are provided to those beneficiaries upon discharge from the hospital and also upon admission to the post-acute provider. So wrapping up, and then I'll turn it over to Kimber, just we put together a kind of a post-webinar for those of you who are still around to do checklists for you of what you ought to be doing. I mean, I think first of all and foremost, determine the historic and projected number of beneficiaries that are admitted to your organization, what's their duration of stay, what's the cost of care for you to care for those folks, and then contact the local referring hospitals that are covered under the CJR mandate and discuss entering into a collaborator agreement if that's where you want to go and if that's where the hospital wants to go. And there's a long list of questions that we talked about here that you should be prepared to answer as part of the negotiations. And if you're going to go that route, then you and the hospital need to make sure that you put together the required notices that have to be provided to counsel. So with that, I'm going to turn it back to Kimber for some conclusions and thoughts here for you.
Well, it looks like we're down to a small number of attendees. I'm glad, I appreciate those that came back. But at any rate, in the interest of providing the whole presentation, when you're looking at the conclusions, I mean, what can be drawn from this model and the test, and what you might be able to do in terms of trying to benefit from it? It's pretty clear that the mandate for a hospital to participate in the program, and they have no choice, and they have to be measured against the target price, requires them to look very closely at the discharge facilities involved in their network. I mean, I think it might be fair to say that hospitals really historically haven't paid too much attention to where they were discharging until recent times in the readmission penalty, and we've moved into an era of preferred provider. Now we're moving one step further, where this will have an immediate financial impact on hospitals that are mandated to participate in the program. So is that an opportunity for you, or is that a potential risk to you? It's an opportunity for you if you can be efficient and, importantly, meet the quality criteria and show that to the hospital. I mean, really what we're talking about is the Medicare dollar. Who is the winner? Who gets the Medicare discharges? Who keeps the Medicare dollar? And for right now, we're talking about roughly, I mean, it's just the knee and the hip replacements, but it's the largest procedures for Medicare beneficiaries. So the implications of this and the opportunities are great. There's quite a few hip and knee replacements in all of these zones, because again, it's the most common procedure. So there should be some real dollars at stake here, and you should have an opportunity to show what you're capable of doing and becoming a preferred provider and becoming a collaborator, which again has implications for you. The incentives that you have today will need to change. I mean, if we have a hospital stay for a hip or knee replacement, and that's 14 days or 12 days, I mean, a hospital will be starting to think in terms of, hey, for a hip, or it's 7 days, a knee, it's 5 days. I mean, the same rules apply. It's not fee for service. It's we're sharing a risk. We have to meet together a target price. We want to win. We have to beat it. And it's all about becoming more efficient. So those are the big issues. Can you participate and be a winner? And if so, it's an opportunity that this mandate is presenting for you. So if you have any other questions, Dave and I would try to answer them for you. And if not, our session is done.